During the current COVID-19 pandemic, surgeons are increasingly aware of the release of viral particles in the plume of laparoscopic electrocautery. Our team has therefore incorporated the use of the APHS for smoke evacuation during laparoscopic urology work. Its filters remove particles down to the size of 100 nanometers to ensure a clear and safe operative environment.
I'm Davide Lomanto, and as endolaparoscopic surgeon, I'm very fond in safety in OR. That's why I use the IS3 smoke evacuator with biogenerator during my surgeries. It gives me peace of mind during this pandemic by removing virus and all dangerous substances and provide me a clear vision during the procedure, especially when I use it with any energy and with loud bisect.
I like the fact that the smoke evacuation occurs during or when I activate my electrocautery or electrical surgical device. In particular, at the end of the surgery, before specimen or port removal, we activate the IES device to smoke evacuate. This ensures a clear air for the theatre environment. I therefore support the use of smoke evacuation devices in laparoscopic surgery.
The IES-3 smoke evacuation system is our solution for a safe and clean working environment. The IES-3 filters smoke and odors and extracts aerosol-charged air during open surgical and laparoscopic procedures. User tests also show that the majority of respondents found the IES-3 to be quieter and more pleasant than comparable units. The 5-stage high-efficiency filter removes virtually all particles with diameters of 0.1 micrometers and more. Thus, this filter offers the best possible degree of safety. Smoke evacuation by ERBA, all from one source.
Okay. Shall we start? Yes. Thank you, ladies and gentlemen, and thank you for all the audience joining us internationally. This is our ELSA in APHS Inguinal Hernia sessions. And today we have 2 lectures and 1 debate sessions. And the first lectures will be produced by Sujit and from Singapore, and he will be talking about TEP plus and new energy technology. And Sujit is a consultant in general surgery and minimally invasive surgery at the National University Health Systems. And he is graduated from the Colombo, Sri Lanka in 2008. And he was accredited as a specialist in general surgery by the Specialist Accreditation Board Singapore in 2017. So without further ado, we go to the first speaker.
Yeah, thanks, George, for the kind introduction. Yeah, I will share my slides. I will see the screen.
Yes.
Okay. Yeah. So I'll be talking about TEP plus, which I will explain in a short while, and some new energy technology which has come into our ORs during the recent past. No disclosures. So the background to this is surgery for inguinal hernia is still evolving. Still, there's new concepts coming up. So seroma, hematoma, recurrence is still a challenge to us, despite all the new advances that we talk about. So new surgical techniques to reduce seroma and hematoma and recurrence, and new technology to improve surgical outcomes for both patient and the surgeon are important. So we published this study in 2019. This is a cohort study comparing closure of a direct defect versus non-closure. We had about 378 patients. So the technique, let me show you the video. So this is like an M3 defect, And the issue with this kind of defects is that, okay, are you able to still see my video, or there's a lag?
No, you are.
Okay.
You have to re-share your screen. So
Yeah.
please.
I have to reshare my screen, yeah?
Yeah.
Okay, let me go back. Yeah.
Yes.
Can you see now?
Yes.
Okay.
Good now. Make it full screen.
Okay. Yeah. Screen.
Yeah.
Okay.
Better.
Yeah. So this is
fine.
So this is a M. Yeah. Okay. Great. So this is a M3 defect. Quite big pseudo sac I can see. So the issue with this kind of defect is that if we just put a standard 10 by 15 mesh, there's a risk of mesh being dragged into the defect. And therefore, what we try to do, we try to approximate the two edges, leaving the inferior area of the defect, because both the neurovascular bundle as core structures travel in this area. Then we try to patch up the defect by using the pseudo sac. So it's more like a patch to reduce the tension as well as to reduce the dead space to ensure that the mesh doesn't go back in. So reducing of the dead space actually helps with reducing seroma formation. And what we found in the results is that so after we close the defect standard, we put the mesh and yeah. So let me go to the results. So results are interesting. So 159 patients were not repaired and 219 were repaired. So you can see in the repaired group that all the parameters mentioned here, like pain, seroma, infection, recurrence rate, all superior. Furthermore, the seroma and recurrence rate is statistically significantly better in the repaired group. So we do practice this in our institutions in Singapore, mainly in where I practice, as well as we have a couple of institutions that we do this procedure. So what we suggest is that this technique, you can do it in both TEP and TAPP. So we call it TEP or TAPP plus technique. It significantly reduces the incidence of postoperative seroma and recurrence rates. So hence should be considered during laparoscopic repair of direct inguinal hernia as an adjunct. So, I mean, people may argue about the pain, but we did not notice a significantly increased pain. In fact, the pain was lower, as you can see. Okay, so this particular study we published was about direct defect closure. So what do we do for large indirect hernia? So we tried this out. The issue with the indirect sac is very difficult to close inferiorly. So we take care not to touch the inferior region where the core structures are, but we still incorporate the pseudo sac and approximate the defect around the deep ring, so that the risk of meshoma and then the mesh being pushed. We are still in the process of collecting data for this particular part, but we found that in a rather big hernia, where usually 10 by 15 mesh won't be adequate, we were able to get away with just putting a 10 by 15 mesh after we are able to reduce the defect size from about 5 to 10 centimeters to about 1 or 2 centimeters. So the defect which is left behind is just at the inferior edge where the core structures are. Okay, so about new energy technology. So effective hemostasis affects surgical outcomes. We all know that, including recurrence, including hematoma, seroma, so postoperative infection. So therefore, energy devices, you name it, monopolar, bipolar, ultrasonic, these are all important, but the issue is the cost. So then all energy devices produce smoke, and you also in that the advertisement that we saw that how harmful surgical smoke is, and there should be mitigating factors. So we started using this instrument. It's an energy device. What is special in this is that it uses bipolar. It's a pure bipolar coagulation and cutting instrument. The advantage over other energy devices is that this is reusable. So I won't mention about the cost, but it is actually relatively, should be cheaper because it's reusable. It has a proprietary bipolar cutting mode. And you can upload your own settings to it, and the servicing can be done over Wi-Fi, and it's IoT ready. How it works is the simple bipolar forces that we use is quite similar to that in terms of the bipolar coagulation. Is operated with a foot pedal. So coaptation and then the simple bipolar technology is used for soft coagulation.
So
cutting
one more minute.
Okay, sure. So cutting is done with sparks and quite efficient. I will just share this video. So this is how usually is done. So not much smoke, quite efficient. Hemostasis is quite good. Okay, I will skip the rest of the videos. Okay, so surgical smoke, I won't go into detail because I think you saw the details about this. So the other thing in terms of this particular era of COVID-19 is important that, you know, about the viruses that we can get, it can get transmitted. And also surgical smoke is a known carcinogen. It has multiple carcinogens, and it actually poses a 10 to 17 times higher risk than passive smoke, passive cigarette smoke. So details about this, again, I will not go into details because you saw most of the details before my lecture. So it actually filters 99.995% of the particles. So it captures nearly all particles, if I'm not wrong. So there's a activated charcoal, which actually sucks up most of the harmful organic compounds. Available with both laparoscopic and open procedures. So these are some considerations that we can look into in terms of new technology for hernia repair to safeguard both patient and the surgeon. Thank you very much.
George, you are muted.
Thank you, Sujat, for your nice presentations. Okay. We'll save the discussion after the next lecture together. And may I introduce you to our next speakers. He's a well-known surgeon around Asia and America and worldwide. And Dr. David Chen. He's actually the current president-elect of the American Hernia Society and served on several editorial boards in the several journals. And his topic today is a complication in laparoscopic inguinal hernia repair. Thank you, David.
Great. Thank you to George, and thank you to Ralph for inviting me to the APHS. It's a pleasure to be here. I'll start sharing right now, and let me start my presentation here. So today I'm going to talk about complications in laparoscopic inguinal hernia repair. I'm at UCLA in Los Angeles, and I'm the director of the Liechtenstein Amid Hernia Clinic. Let's see if I can, there we go. So this is a new world, and we're socially distanced, but we're definitely not isolated. So even though I can't see all of you, it's nice to see good friends on the panel, and I'm glad that we can still share this way. So groin hernia is important just because it's a bread and butter of us general surgeons of what we do. 20 million surgeries worldwide, and we've done well in the era of mesh with recurrence rates around 2%. But really significant pain is our most important consideration, 6 to 8% of patients. And if you talk about an inguinal hernia repair, aside from, you know, the true incarcerations and strangulations, really the outcome that your patients care about is quality of life. And that's kind of our most important goal to reach for. The hernia surge guidelines, we know that there's some basic things. The gist is that mesh is recommended. We use it because we do better. And no one standard repair exists. If we care about doing a good job, we want to be able to provide both an anterior and a posterior repair Liechtenstein and laparoscopic, or MIS, remains the best evaluated. And this was the first time that we actually recommended, when we look at all the data, that if you have the resources and the expertise, MIS techniques are recommended. So what's the benefit of MIS inguinal hernia repair? So we know that there's a faster return to work and normal activity. We know that there's the advantages for if you have a bilateral hernia. It repairs all types of hernia, femoral and obturator. So if you have one hammer, this is the right hammer. Lower rate of chronic pain, sensory disturbances, and it's the optimal approach if you have a recurrence after an anterior repair. So what are our challenges? Well, it has a steep learning curve. We know that if I'm teaching a Liechtenstein in a developing country and I have a good surgeon, if I do 5 operations with them, I can walk away and be comfortable that they'll do a good job. But we know that that's not the case with laparoscopy. If you don't do an adequate dissection, if you don't view the MPO, the myopectineal orifice, completely, you'll get folding and mesh migration. You can lead to pain from not recognizing the nerves in the triangle of pain. You can put mesh in the wrong plane. Defect closure and can cause entrapment neuropathy. A very important thing when you're doing a TEP or TAP plus, as you saw, you have to be very careful about that. And these rules apply to TEP, TAP, ETEP, RTEP, RTEP, all variations of MIS surgery. And the goal is we need to standardize it. When we look at that, these were not the 2 people that started the technique, but they really have worked worldwide to help a general understanding of how do we perfect this operation. So in the United States, Professor Ed Felix, and in Europe and all through Asia, we know that Professor Reinhard Bittner have really worked to standardize the operation. And this published in Annals of Surgery in 2017 with my good friend Jorge Diaz and Ed Felix, the critical view of the myopectineal orifice, that we can look at the groin before we put in our mesh and say, if you don't have this picture where you see all spaces and get this critical view, you don't put in your mesh because you haven't done the right dissection. This is the 10 Commandments, as Ed Felix said. This is updated with this new article into just this year with our Brazilian friends, Cristiano Claus, the Brazilian Society president, and Ed Felix, where instead of the 10 Commandments, they went New Testament and called it the 10 Golden Rules. But basically the same thing, that we are looking at standardizing this operation. And if you look at Professor Bittner's book, Laparoscopic Hernia Surgery, he talks about the anatomy being so important to a good operation. When we talk about hernia repair, you have to understand that all repairs can cause pain. If you do an open anterior repair, you have to think about the anterior nerves. If you do a laparoscopic repair, you have to think about indirect exposure to the nerves. And this, despite all of the hoopla, is not a mesh problem alone. Inguinal hernia surgery is complex anatomy, and you have to think about the nerves, the tissues, but you can maximize and optimize your technique to have good outcomes. So what goes wrong in an MIS surgery? So in a good operation, you'll obtain a critical view of the MPO, the myopectineal orifice, in every case. What does that do? It prevents clamshelling and missed hernias. So if you don't see this critical view, the direct, the indirect, the femoral, triangle of doom, triangle of pain, the iliopubic tract, and good clearance, 2 centimeters below Cooper's ligament, then you don't have a landing zone. So you need to stop and say, do I have an adequate landing zone? Have I seen all the structures? And if you do that, then you won't miss the femoral hernia, the obturator hernia. You won't lead to this, where the pocket wasn't big enough and you get clamshelling, where your flat mesh is now a meshoma. So what other things go wrong? So you saw in the TAP Plus and the TAP Plus suturing the defects. Now you saw that Sujit showed you a good example of imbrication. And so it's very important to imbricate and not close the defects, because if you close the defects, you can entrap the nerves on the other side. It's the same concept. Here you'll see this is a big scrotal hernia, and my friend Eddie Parra, he's showing an example of sewing the defect shut, whereas this is an example of imbricating. The difference is the transversalis fascia gets just imbricated here as opposed to actually trying to close the defect. The problem with closing the defect is that I see about 300 patients a year with pain from hernia operations, and we see all variants. I've seen, this is a nerve caught by a robotic suture. You can see it entrapped here. I've seen the whole cord taken by a stitch. So you don't want to get anything on the other side. So good surgery, you'll minimize fixation, no tacks below the iliopubic tract, and I would argue, if possible, no tacks at all. The only free tack that you get is Cooper's ligament, and also fixation cannot fix an inadequate dissection. So if you're doing an MIS repair and you don't fixate at all, you only really need to think about 2 nerves, genitofemoral and the lateral femorocutaneous. The femoral and genital branch.
David, one more minute.
Here, the genitofemoral, and here's the lateral femorocutaneous. But if you fixate, you now need to think about the ilioinguinal and iliohypoglossal hypogastric nerve. There's a lot of variation there. And you can see that this whole myopectoneal orifice, these tacks are a little bit unsafe because it's like Battleship, and you can hit these nerves from the other side. Okay, so you don't want to over dissect the triangle of pain. There's two planes of the preperitoneal space. There's transversalis fascia that covers your nerves, and here you can see the nerves are naked here in the visceral compartment. And if you put a mesh against a naked nerve, you'll cause pain and neuropathy. So next, you need to reduce cord lipomas. If you don't reduce a cord lipoma, you can then lead to this where you have a retained cord lipoma. And even though it's a pseudo recurrence, patients will feel it as pain. How do you tell a cord lipoma from a lymph node? It's lobulated versus a cord lipoma comes from the retroperitoneum. The important thing is when you do these cord lipomas in indirect dissection, this is the genital nerve. You want to make sure you don't over dissect this. And I really, really would advocate don't sew that shut. So next, don't manipulate the cord structures. If you do, the problem is that you can injure the paravasal nerves and cause orcalgia. Don't prophylactically place a mesh in a side that doesn't have a hernia. This is a nerve entrapment. And when I remove the mesh, there's no hernia here. So this patient didn't need that problem. Don't tack lateral to the psoas. Here you can see this gentleman had a tack right into the femoral nerve. He came in a wheelchair and couldn't walk. And this is right after surgery. You can see this is not a complication that you want from an inguinal hernia. For last few things, don't split the laparoscopic mesh around the cord. Some people advocated split mesh techniques. In the early days, this was advocated to try to replicate a Liechtenstein, but you can see what it does. It constricts the cord, craps the nerves, and then as it constricts, you can also get these reactive hydroseals and pain from that. In general, avoid mesh in contaminated fields. Although we can get away with it sometimes, we'll see that in the next lectures. If you have contamination, this is a bad problem and you just don't want to infect your mesh. Last thing, avoid microporous, heavy meshes, and excess fixation. This is an example of the mesh eroding right into the colon. And you can see here, this is the colon, fistula right into the mesh, tack right into it. And the last, check your mesh at the completion. Ensure that it's flat. What does that do? So at the end of my surgery, I deflate, make sure it's flat. And then I like to pop in a TEP and take a look what it looks like from the inside. And it prevents this, prevents the clamshelling that we see here. So close your defects if they're greater than 1 centimeter so you don't get bowel obstructions. So what are the conclusions? If you want to do a good MIS repair, you need to understand the posterior anatomy. That's crucial to the outcomes. Understand your preperitoneal space. The extent of dissection and the mesh position are the key to prevent recurrence, and nerve recognition and careful dissection are the keys to prevent pain. This is Parvez Ahmed, who was my mentor, and Irv Liechtenstein, who was his mentor. And the key to hernia surgery is we're a family and we love to teach each other. You're always welcome at the Liechtenstein Hernia Clinic. I'm the president-elect. I'll become the president on September 26th of the America's Hernia Society. This is the link for our meeting. It is virtual and it is free and open for all of you. We'd love to see you there. Thank you for the opportunity.
Okay, thank you, David. Okay, so maybe we can look at the question box. Are there any hot and burning questions for the two presenters?
Yeah, there were 3 questions, George. The first one is about nerve entrapment. I think that topic has been well covered by David, so we don't need to go into more details here. But then there are 2 more on pain, how to minimize pain technically and what to do to minimize post-operative pain.
David, do you want me to answer or you want to go ahead?
You can answer.
Okay, so I mean, we can basically divide this into acute post-operative pain and chronic pain. These are completely different 2 entities. So I would talk about acute post-operative pain. So what we usually do in our institution is that before we start the incision, we give local anesthetic, and this minimizes the amount of opioids being used. So. And before I put the mesh, what I have started doing is I give local anesthetic around the region of the psoas, as well as, I mean, this is being published, but not very effective. The results are not very promising, but if we can do it properly, it works. So all my patients, even inguinal scrotal, everybody go home the same day. So this is how I have handled the postoperative pain. Chronic pain, David, do you want to address that?
I think that, you know, the whole lecture kind of centers around that. The main things would be recognize that you need to protect your nerves, especially from the dissection for the genitofemoral and lateral cutaneous, and from the absence of fixation or suture when you talk about iliohypogastric ilioinguinal. Make sure that your pocket is well dissected so you see the whole MPO, and that will prevent you from missing a hernia, and that will prevent you from your mesh folding. Those are the main things that drive pain in the chronic situation for patients with the MIS inguinal hernia repair.
Maybe one comment from my side. What we are doing, or what I'm doing in inguinal, is at the end of the operation, I inject local anesthetic around the trocar sites and in this space. And from inside, you can spray a few milliliters of local anesthetic into the space before you either leave the space in TEP or you close the space in TAPP. That helps not to prevent or to treat surgical mistakes, but it helps definitely in preventing the immediate postoperative pain, not the chronic one.
Yeah.
Yes.
Yeah, I do the same actually. Yeah.
I'll tell you a funny story about that, Ralph. I typically don't do it. And I reoperated on our friend Ed Felix, and he had a prior knee hoose repair, and he had two prior repairs, and everything was stuck. So I did a redo, I did a TEP on him, and at the end of it, I never do it, but because he's a friend, I squirted local anesthesia. And in the recovery room, he had a femoral nerve palsy, totally asleep. Once in a while it can happen, and so I like to inject the trocar sites, but I've only done it once, and one for one I got Ed Felix. So
David, I had the same. But how to mitigate this? I discussed with our anesthetic colleagues. So there's a very low concentration that can only
you have to dilute.
So yeah, exactly. Then it doesn't happen. Yeah.
It was unique to the fact that he had a reoperative surgery from a knee hoose repair. So your femoral nerve is going to be a little bit more exposed when you redissect. Yeah. But in general, that you have to just be careful about.
That's the typical scenario if you operate on a friend or on a colleague. You know?
Absolutely.
High risk. Yeah. Good. There's another question just popped up on seromas. Who wants to take that one?
I can talk about that. You know, in general, if you have a seroma, just reassure the patient. The thing is that if you do like Sujit showed you and you imbricate the direct space, you'll decrease the seroma risk. But the reality is that if you get a seroma, almost always it's benign. There's so minimal reports ever of anyone actually infecting from a seroma. You're more likely to cause trouble if you go poke it a few times and then you have mesh behind that. So I tell the patients, don't worry about it. It will go away. If it's still there a month later, or it starts to give them symptoms, sure, you can aspirate it. But otherwise, just reassure them.
Yeah, totally agree. Yeah, I mean, all surgery actually have seroma, like breast surgery, inguinal hernia. When you have a dead space, it's just a normal physiological response. So you should actually tell your patient preoperatively and prime them, so none of them will come back and hassle you for recurrence. Totally.
Okay, I think there are no further questions, and we can proceed with the second part of this session, which is the debate. Now, I have the honor and the pleasure to introduce two of my good friends here. George, he doesn't need introduction because he is well known, not only in APHS, but also in ELSA. And of course, Maki, sorry, I have to say, Jose Macario Filona, but we all know him as Maki, and both are EXCO members of APHS. I'm the president of APHS just right now, and I really like to congratulate David to take over the presidency of AHS in not even 2 weeks from now. So my congrats to you, David, and thank you very much for the invitation to be part of AHS in a few weeks from now. Now, the debate is actually about strangulated hernia. So the two experts will discuss with you now, and please put some fuel on the fire, what to do in strangulated hernia. Is it the best way in laparoscopic approach, or do we need to open in strangulated hernia? I think, George, you will take the lead.
Okay, so just gonna share my screen now. Can you see my slide?
Yeah.
Yes. Okay. Okay, so I'm going to talk about the laparoscopic side. Okay, for strangulated hernia, it's actually quite common in the community, and one of the commonest cause for small bowel obstructions. And fortunately, the disease actually presented in a wide spectrum of presentation. Some people may just have a strangulated omentum or partially strangulated bowel, which is easily reduced. To the other extreme, you can have a strangulated dead, like small bowel perforated, or sometimes even strangulated bladder. Okay, so when we introduce minimal access surgery, all we try to do is actually improve the clinical outcome. So how are we going to improve clinical outcome? So we need to break down each individual components to analyze. Okay, for open surgical approach, the major causative factor for morbidity and mortality is actually laparotomy and bowel resection. And some surgeons have said that the first intention of exploratory laparotomy in strangulated hernia is the major cause of postoperative complications. Also, we are dealing with elderly age groups most of the time, and yeah, that's so these are the key components for morbidity and mortality. And so if we can reduce this, then we can do some good for the patients. Okay, so there are a lot of argument in laparoscopic repair for strangulated hernias. So the first one, most people are asking whether mesh is safe in this situation, and what benefit does it do, and why do this benefit happen in laparoscopic arm, and most importantly, how to do it. Okay, so mesh is actually safe in majority of the case of strangulated hernia, because even in open repair, a lot of people still do Liechtenstein repair in majority of strangulated cases. Because as we said, the strangulation actually they present it as a spectrum. They don't actually all have a perforated bowel contaminated surgical fields. But in the extreme situation, when you have perforated bowel and very contaminated fields, then obviously you can either opt for tissue repair or stage repair. And in those cases, but mesh is not safe. But in majority of the cases, mesh is actually safe. And as I said, in open surgery, people do Liechtenstein repair as well. Okay, so how does MAS help? Okay, so we actually did studies and we look at the details, and laparoscopic arm actually did have a very low laparotomy rate and also lower bowel resection rate. And why is that? And when we analyze, it's actually because there's simply a change in the sequence of surgical steps. So time is the essence. Okay, in open surgery, all the time we allow for bowel recovery is about 10 to 20 minutes, and surgeons have to decide whether we're going to reset the bowel or proceed ahead with laparotomy. But in MAS surgery, actually the sequence is actually switched. So in most of the case, we actually allow about 60 minutes to 90 minutes for the bowel to recover in warm intraperitoneal conditions. So the much more time is allowed for strangulated bowel to recover. That's the major essence, and that's the key impact to reduce the postoperative complications. So we have an open surgery on this arm. You can see after you open the hernia sac and assess the content of the strangulated bowel, then you have to decide whether you need a laparotomy or bowel resection. But this step in laparoscopic repair is actually moved down to here. So in laparoscopic, once you put a scope inside the peritoneum, you reduce the hernia. The next thing, you are going to repair the hernia. You can actually repair still by open repair, Liechtenstein repair, or you can proceed to laparoscopic repair. It doesn't really matter. But after the repair, then we go back to reassess the bowel. This gives a lot more time for the bowel to recover, and hence this will reduce the laparotomy rate, and also most of the bowel can recover with ample time. And then after that, then closure of the wound. So we think this is the key in MAS and in arising with a lower morbidity and mortality rate. Okay, so how do we do it? I think patient selection is most important. Okay, so those are hemodynamically unstable, so who have a perforated bowel, like shock and probably this is not suitable. But preoperatively, I think if possible, we should have a CT scan of the abdomen. We want to gain as much information as possible. Why? Because in laparoscopic surgery, the disadvantage in MIS surgery is that because we operated in a limited space, so we should have as much information as possible. We don't want to be caught unexpectedly. So you know which hernia you are dealing with, where the hernia is, and what is herniated through the hernia. Okay, so the next most crucial step is actually reduction of the strangulated content. And once you've done this step, the surgery is almost finished. Okay, so this is the most difficult part in the whole surgery in MIS strangulated hernia. So after we put a diagnostic laparoscopy, usually most of surgeons will use a transperitoneal reduction. So we have our scope in the peritoneal space, and you try to reduce the hernia. And usually we try to reduce the hernia by mainly rely on external manual compressions. Okay, because the bowel is edematous, you have to handle the bowel very carefully. You don't want to cause any tearing of the bowel or perforation of the bowel by your grasper, laparoscopic grasper. So you have to be very gentle. Okay, and so in the early era, some surgeons are actually using an totally extraperitoneal approach. But this is probably not well adopted by most of the surgeons. So we should use external compression with internal manipulations. Okay, what happens if you can't reduce the hernia? In severe case, in extreme case, if you really can't reduce the hernia, then you can actually make an incision over the groin hernia site and using a hybrid approach, as suggested by Anil a while ago, and then using this approach and open the inguinal hernia area and release the ring, and then reduce the hernia. Okay, so this is a short video on strangulated hernia after previous repair. Okay, so mainly with external compression, you can reduce most of the bowel. Just fast forward a little bit. And then because it's a chronic hernia as well, you can see there's an adhesion to the hernia orifice. And when you grasp the bowel, you have to be very careful not to cause any serosal injury. Okay, so you can see the adhesion here. That's why the bowel is very difficult to reduce. Okay. And this is another case. Lady presented with strangulated femoral hernia, and she's actually 101 years old. She just presented a few days before her birthday. Okay, so you can see the space is actually very limited. So when you use the trocar, you must use a blunt tip trocar. Do not use any sharp tip trocar. These bowel are very easily injured by laceration. And you can see the femoral hernia. Okay, the femoral hernia is stuck very tightly. Okay. And when you see this situation, that's actually better to put a gauze in. So in case there's any leakage or perforation, then you can use a gauze to cover it. And you can see the bowel is actually not very healthy. So we just plicate the bowel and then proceed to hernia repair, and then come back to resect this part of a bowel with a small extended umbilical wound. And the patient recover much faster instead of a laparotomy. Okay, so after the surgery, whether you do TEP and TPP is basically based on your training. But for most of the surgeons, actually a lot of people will choose TEP because you operate in an extraperitoneal space. So you avoid your instrument injury to the chance of instrument injury to the dilated bowel. Okay, and when you do a TEP repair, you have to be careful of your port selection because you don't want to have a diagnostic transperitoneal port within the TEP zone, where otherwise you will have a gas leak. Okay, so this is the problem with TAPP in dilated bowel situation, bowel obstruction. So, okay, reassessment of the bowel. So this is another case of strangulated hernia. You can see initially the bowel looks like this. After that, you can see the color return and peristalsis return. So in this case, we actually decided not to resect the bowel. So this is just a flow chart. Okay, so when you have a triangular hernia, and when the patient is hemodynamically stable, we can do a diagnostic laparoscopy and reduction of hernia. And then after that, the surgeon have to determine whether mesh is suitable or unsuitable, and then decide on what repair, even open repair in laparoscopic arm, and then you can do a laparoscopy to reassess the bowel. And the bowel, if we deemed to be needed to be resected, then we can do it as a through an extended umbilical wound.
Please conclude, George.
Yes, this is a summary. So MIS does have an advantage in triangular groin hernia situations. But first, you must acquire enough experience in both laparoscopic hernia and emergency laparoscopic surgery in a state of bowel obstructions. Okay, and this can achieve in avoiding unnecessary laparotomy and lower the bowel resection rate. Thank you.
Thank you very much, George. We will straight go ahead to Maki, and our past president will give us his view on the topic. So I'm very curious, Maki.
Can George, can you stop sharing? I cannot share. Yeah, there. Okay, so.
Okay.
Wait. Okay, there. Can you see my slides now?
Yeah.
Okay. So the debate pointed me to go into the open approach for strangulated hernia as assigned by George to me. I have no disclosure except that I know that this debate will be a bit difficult for me, having to debate with someone who has published 2 articles on laparoscopy for emergency hernia repair. So just some data, we all know that there's about 20 million cases being done annually for hernia, and majority would occur in men. However, if we look at the statistics, there are more emergency cases or strangulated or incarcerated cases in women due to the incidence of femoral. This is the recommended option. When you put the mesh, you either use open or endoscopic technique. And as mentioned by George, about 3% of these cases go to open, the emergency situation due to some form of strangulation or incarceration. I did this informal survey I think it was last year, and just to look at the field wherein how is the acceptance of laparoscopy versus open surgery for groin hernia. And if you would look at the data, except from Germany, which approaches about 80%, majority of the countries like the US, the UK, even in the Philippines, the acceptance of laparoscopic surgery for groin hernia occurs to about just 30%. And in Switzerland, this is a very nice data. You would note that even though open surgery is about 60%, the laparoscopic approach is being used by about 40%. But look at the data for surgical trainees. Surgical trainees, majority would still do the case open surgery rather than laparoscopic. So we all know that for emergency groin hernia, most of the cases would come in due to acute incarceration or incarceration with bowel obstruction, incarceration with strangulation. And as I mentioned before, a lot of the females that might come in as an emergency, there's a risk of strangulation due to femoral hernia. This is an algorithm published by our very good friend, Ferdinand Kocherling in 2018. And if you look at the emergency side, this part of the graph or the table would show that if you are entertaining already a transmural peritonitis or a bowel gangrene, then certainly the technique would still proceed now to do the open technique rather than the laparoscopic technique. Or even if you push the laparoscopic technique, then it has to be a staged operation as mentioned in this algorithm. So as mentioned by George, of course, laparoscopy has an advantage of observing the bowel. When you reduce it inside, you have the time to to observe it. You have a warm environment where you can put normal saline, warm normal saline, and watch if the bowel is improving. But one thing going against laparoscopy, as mentioned, is that it will require expertise in doing the procedure, more so if you're dealing with an emergency case. And also, as mentioned by George, there is a bit of a question whether it's actually safe to put in a mesh in a possibly contaminated field. So recently, I posted a poll in the IHC just to see how people would react in doing TAPP, for example, and after reduction. And you would know performing the hernia surgery at a later date. And the other, about 41 votes said that they will do the bowel resection and eventually concurrent tissue repair. If you look at the same polling situation which I made for our local society, majority of the surgeons would do bowel resection and open tissue repair, and the others would also do a staged operation. So as you could see on both data from the IHC and the Laparoscopic Society, the decision whether to do laparoscopy or to do open hernia repair or laparoscopy with open tissue repair will actually depend on the locality if the expertise for laparoscopy is there. So what is my argument against laparoscopy? Laparoscopic groin hernia surgery, of course, requires a sufficient skill and therefore would also need more skill if you're dealing with an emergency surgery. Of course, only excellent results can be achieved if you are an expert in doing the procedure. And as I mentioned, emergency hernia surgery is not easy to do. And again, there's the question now whether you can use a mesh if you have done a bowel resection, because if you do develop a leak, then certainly your mesh has to come out, or there's a potential risk of having a mesh infection. So some surgeons would actually do bowel resection and subsequently do an open Liechtenstein repair, since the mesh is placed in a different plane compared to the laparoscopy. And that brings to the point that there is really an advantage of just doing an open technique, because when you open the hernial sac and see that the bowel is compromised, then you can just relax the internal ring and also observe externally and proceed with whatever thing you need to do, like a bowel resection or even a Liechtenstein repair or even just a tissue repair. So it's not a staged approach. Also, if you do bowel resection plus a staged approach, then this will entail a higher risk and cost for the patient. So the argument now for the open approach is that you can actually approach the problem in a one-stage approach, do bowel resection and do a tissue repair, or do a bowel resection with Liechtenstein repair if you are brave enough to put a mesh after doing a bowel resection. Again, most cases can be done under regional anesthesia. You don't require general anesthesia as required by the laparoscopic approach. As I mentioned, you may opt for tissue repair if you are dealing with a contaminated field and you don't need to do a stage approach, and approach the recurrence when it comes later on. And you can actually do a Liechtenstein technique if you are only suspecting transmural peritonitis. So that's the last slide, and I would like to thank you all for your kind attention.
Great presentation, Maki, and thank you so much for keeping the time. So I don't see any questions in the chat box, but I have some. So I had the pleasure to prepare a presentation on hybrid procedures. So the combination of laparoscopic approach ending up in a part which is done in an open way. George has mentioned this. And to my surprise, although this technique is there for the last almost 15 years, has been described in the mid of 2005 first, there's only one single randomized controlled trial on this topic, which comes basically from Finland. Ahonen has published this in this year, 2020. About 200 patients were randomized in 2 groups, and the outcome was no significant difference in nothing. However, very interesting in this study, they don't comment on the expertise of surgeons. So now to both of you, what is the level of expertise you expect the surgeon to have if he approaches an emergency situation knowing that there is an incarceration?
You want me to go first?
Yeah.
Oh, for the open, it's easy. It's as mentioned by David, being a master in the Liechtenstein technique will not entail a very high learning curve. And most of our trainees, of course, are already trained in doing open technique for hernia surgery and do bowel resections. So the only option of doing a laparotomy is that if you are not sure whether your bowel compromise is just limited into that bowel which is extruded out, or you are maybe suspecting something inside. But otherwise, as mentioned by you, you can actually do a hybrid. If a surgeon who had done this procedure open suspects that there is something inside, you can actually use a laparoscope and go through the internal ring and visualize inside if there is something wrong. But in terms of level of expertise, I think it would be easier to approach this by an open technique compared to the laparoscopy.
I agree with you because it's a matter of safety. However, George, you are the director of the minimally invasive department and robotic surgery. So what is which one of your surgeons you would allow to do this laparoscopically only? You're muted, George.
Okay, so I think it's a similar situation in acute cholecystitis, and who do you allow to go in for acute cholecystitis and who do you allow for strangulated bowel? First of all, laparoscopic hernia repair is actually one of the most difficult in comparing appendectomy and cholecystectomy. In our training, laparoscopic hernia repair is actually the advanced laparoscopic training skills. Okay, so unfortunately, you are right. And in order to do a laparoscopic MIS approach for strangulated hernia, then I think for me, I will allow like a senior surgeon to do it. So in Hong Kong, it's actually associate consultant. Okay, so
do you have a sound privileging process in place for this?
Yes, yeah, we actually have a very well organized training scheme, and those who achieve associate consultant, we already have the skills in going into the emergency laparoscopic surgery.
Great.
And then I just want to raise one comment in open approach, like, for open approach, if it's a strangulated inguinal hernia, it's still okay. What happens if the trainee, if it's a basic, come in and open up and find that it's actually strangulated obturator hernia or strangulated femoral hernia, then it will be very complex, and then you don't know what they did in the surgery. But in a laparoscopic approach, one of the key advantage is in ladies with strangulated obturator hernia. So you can still repair. Yeah. So
thanks, George. We have a comment from David.
Yeah, so I have a few comments. So you guys gave wonderful presentations, and George, when you were showing reduction and you show a very gentle reduction with blunt graspers, that works fine. But you also have many videos where the bowel's so attenuated that you pull and the bowel rips. So just remember that depending on your hernia, you can also open the hernial orifice a bit, and that will help your reduction. So if you have a femoral hernia, you cut superior, so you're cutting the iliopubic tract. If you have a direct hernia, you cut superior medially, so you're away from the infraepigastric. And if you have an indirect hernia, you cut superior laterally, so you're away from the infraepigastric. And when you just open the ring a little bit, it will make the reduction easier. My most important comment is that just remember that when a patient comes in with a strangulated, incarcerated hernia, their problem is not hernia. Their problem is visceral. And so what you care about most is the bowel, and that's what's going to kill them. So yes, there can be a mesh infection, and yes, there can be a recurrent hernia, but that's a problem for another day. What you want to do is you want to deal with the bowel. So if you have the capability, there's no better way to work on the bowel than laparoscopically. You put in a laparoscope. If you need to transect the bowel, you can fire a stapler, you can pull it out through a small incision. That's great. The hernia, figure it out afterwards. So you can do whatever. If you know how to do a tissue repair, great. If you're great at MIS surgery, you can then go to a TEP plane and you're clean. You always have to remember mesh. If it's colon, don't use mesh. If it's small bowel, you probably can get away with the macroporous mesh, but you can always just wait. You know, you say that, yes, they'll be in the hospital longer. That patient's not going anywhere. That patient's there for a few days anyways because of the bowel. So then you can also fix them right before discharge, go back and do an open or a laparoscopic repair. So just remember, the key point is that the patient dies from a bowel injury, not from the hernia.
Yeah. Thanks, David. Very valid comments. Our host is reminding us that the time is up. George, some last remarks. You are the main moderator.
Okay, all right. So thank you everyone for sharing our talk, and thank you for our audience for their patience and participate in this event.
I think it was a great session. Thank you to the speakers. It was really well done, all of you. Thank you.
Thank you.
Bye, guys. See you.
Bye. See you soon.
See you.